The treatment options will vary according to the type of kidney cancer you have. And for this purpose, I'm just going to discuss clear cell, which is the most common because there is some overlap with the others. The first will be getting, as I had said earlier, a proper understanding of exactly if you need treatment, if indeed it's gone past your kidney or you're at high risk to do so. There is a range of newer treatments, some of which are very, very recently approved by the FDA. And those would include immune therapies, what they call targeted therapies, and then cytokine therapies. Kidney cancer is pretty challenging in that it is slow growing. And most chemos that we think of act because cancers are fast growing, and that chemo can kill the faster growing cells, cancer cells, while the slower growing normal cells are less affected. That doesn't work for kidney cancer, therefore the need for these different kinds of therapies. So a targeted therapy, an example of which would be Sutent or sunitinib, might bring down the blood vessels that support a tumor so that it can be either removed again surgically or perhaps diminish, become stable, or shrink. The same could be said for other drugs, including some of the newer immune therapies. And all of these, however, are generally not to be curative in nature. They are to slow the growth, perhaps make it possible for somebody to do additional surgery if the metastases can be reached that way. So in addition to medications, there are additional surgeries to go after metastases in the lungs or liver. There could also be ablation, which is one of several forms of directed radiation or freezing of tumors that can be, and that can be very helpful for where somebody cannot tolerate more surgery. And then the original, and for the longest time, the only therapy that was used for kidney cancer with any effect is high-dose interleukin, which is kind of the foundation to the immune therapies. And I'm particularly biased in considering its use because that's what has given me the last 12 years of my life. I had metastases throughout my lungs. There was no way they could be either surgically removed or zapped with the ablation techniques. And so I needed a systemic treatment, which the meds could also be called that. And that high-dose interleukin revved up my immune system, which recognized the metastases, attacked them, and removed them. That's an unusual situation, but it's one that's led to some of the basis for the newer immune therapies. And I think the other thing that has to be going on at all time for patients, whether they had a smaller tumor, even a small version of the small tumors, is proper monitoring. And that monitoring means to measure by CT scan, certainly the kidney to see if there's a return. And again, because some metastases not seen in the first CAT scan of the lungs, for example, they can continue to grow, and so there should be an ongoing search to see if new mets, previously unseen, are emerging. About 1/3 of all patients who come into a kidney cancer diagnosis have metastatic disease at the outset, and another 1/3 will have metastases after that initial diagnosis that were not found at the time of the diagnosis. So monitoring with CT scans, I think, is essential.